Sure. Okay, lovely.
We will be using Slido, so there is about 60 people online, and if they have any questions, that will come through to that, and then they'll pass those questions through to me. Okay?
Okay, thank you. Perfect.
I think at the end, because I'm the last speaker, do you want me to hand over to you? Do you want to conclude with notices for the future?
Yes.
Or just, yeah.
Yes. And I'll just wait.
Okay, yeah, good.
You ready to go? Okay, I'm just going to introduce. So are we right to go, Chris? Yep, cool. Good evening, everyone. Thank you for coming and welcome to the Queensland Wounds Australia Education Evening this evening. And our focus this evening is on surgical wounds. So we have a variety of presentations this evening, which I'm sure you will find interesting. And there should be something there for everyone. Welcome to our viewers who are from Australia-wide. We have about 60-something people, members of Wounds Australia, who are Skyping in this evening from the Northern Territory, Western Australia, Victoria, Torres Strait. So we're a mixed bunch tonight. So we hope you enjoy our presentation, and you're welcome to join us at any time. So our first presentation this evening. Actually, the other thing is, for those of you online, we'll be using Slido for questions. So you should have received a link with your registration. So if you have any questions towards the end of the presentation, if you could send that through, and we will relay your questions to the presenters. So our first presenter this evening is Jennifer Walker. Jennifer is going to give a presentation to us this evening on radiation-induced wound management. She's a clinical nurse at the Radiation Treatment Unit here at the Royal Brisbane and Women's Hospital. Jennifer has 16 years experience, and she has completed 2 graduate certificates, first in medical surgical nursing and the second in health science, majoring in health professional education. Jennifer has experience working in the Skin Integrity Unit and in plastics here. And in her current role at the Radiation Treatment Unit, Jennifer has worked on clinical trials investigating the management of radiation-induced dermatitis. She has extensive knowledge in complex wounds and clinical scenarios and has a passion for sharing her knowledge and skills. So I look forward to what Jennifer can share with us this evening. I'll ask you to all welcome Jennifer, please. Show you how to use just to click on. Technology, give us a moment. Are we right? Chris, what are we pressing? Should go to you. Go ahead and get to full screen, please.
Yeah.
Yep. Okay.
While we organise all of that, I'll say thank you very much for inviting me to come and speak here. I know that it is a surgical approach to wound care presentation. However, we do a lot of work. Either we are doing a lot more pre-surgery work with patients, or also the cohort of patients that we're getting are really quite complex. So you might actually come across these wounds within the acute care setting or out in the GP community setting. So that's kind of where we come in to this presentation. So my name's Jennifer Walker, and we'll be talking about radiation skin reactions tonight. Okay, so we're just looking at the normal structure of the skin. So when we're looking at radiation-induced dermatitis, it is a gradual process over time because it is an accumulative dose over time. And so it does take around about the week 3 before you would start seeing any breakdown of that skin tissue. And so what happens is between day 10 and 14, you start getting that basal layer of skin cell damage. So you start getting this drying and flaking over the whole treatment area. And then progressing it, you get further damage and new cells reproduce and the old skin cells shed, which is dry desquamation. So when you think of radiation skin reactions, when you have been burnt previously in the past from the sun, you go red and then you peel. With radiation skin reactions, it's actually the other way around. So you dry and peel before you develop any colour. And so really over the years, the change has been, instead of waiting for a wound to come about, we now pre-manage that through different products, because we know that prevention and locking in those moisture is more important than managing it at the later end when the damage has already occurred. And this is exactly what I just mentioned. So when you get a burn injury, it's from the outside in, whereas the radiation damage is happening from the inside out. So you get that migration of the basal cells up to the surface, and over time it can't keep up with that movement, and then you go to a dry shedding and then a moist wound after that. So there are a few factors which contribute to skin reactions. You've got the dose and the large field, whether the patient has had any previous radiation exposure, such as sun exposure. So your head and necks are always very susceptible to complex skin reactions. They also look at what energy are we using in order to treat the patient. Are they on radiosensitizers? And, you know, what other lotions and potions they're putting on the skin. So things like deodorants and temperatures and friction and rubbing, that all comes in with the patient education that we provide. And then the intrinsic risk factors. So we know that aging tissue, it's not as elastic as your younger tissues. Nutritional intake, probably this is one of the things that has a lot more impact upon how the patient's skin goes. So we know that once they start dropping off with their nutritional intake, their skin and all the other side effects usually go with that, and they start increasing. Smoking and alcohol, that's just in regards to the blood flow and availability at the wound base, comorbidities, obesity and infection. So nationally we use the CTCAE, so whoops, sorry. Sorry about that. We do use a CTCA grading scale for radiation-induced dermatitis, and that's both nationally and internationally recognised. So it does go from a grade 0 all the way to a grade 5, which is ultimately death, and there have been deaths related to infections from skin reactions. I can't be left in charge of anything. Computers. Okay, so grade 1 is a faint erythema. So this would be usually from weeks 3, because we treat Monday to Friday, so the 5 days in the week to get to your 14 or 15 fractions. The skin will become dry, a little bit pink, and they might notice that they're a little bit sensitive or itchy in that area. So the management for a grade 1 at the moment is actually Strata XRT cream. Back in 2019, we did a large cohort study within radiation treatment unit at the Royal in regards to silicon-based products and their ability to prevent or delay radiation-induced skin reactions. So silicon acts like a glass house when you think that it's basically sealing in the moisture that your body already has. And so if you can't have any transdermal loss of moisture through your tissues, those tissues are better moisturised, and then it delays a radiation skin reaction. It is a product that we have budgeted within our budget to supply to patients here at the Royal Brisbane. All they have to do is apply it 2 times a day. So when you look at the traditional creams such as sorbolene cream. We knew that the more you apply the sorbolene cream, the better your skin went throughout the treatment, but it could be time consuming and patients don't like rubbing it on, they don't like the smell of it. So it is still worldwide practice to use sorbolene cream, but certainly the use of silicone products are coming in, which is brilliant. We also recommend that they can't apply the product up to 2 hours prior to their radiation because there is concern of a bolus effect. So when we treat a patient, their skin layer is kind of the starting point for how deep we want that radiation to go. And so if you are heavy-handed with creams, that could create a false surface starting point for the radiation. So it's recommended not to apply that within 2 hours prior to your treatment. We're also using a lot of Mepitel films, which is an adhesive silicone, almost like a contact layer. It works exactly the same as your strata. We do find that it helps to prevent friction, which is also another thing. So we use Mepitel film on a lot of breast patients here at the Royal Brisbane because we know axillary and inframammary fold are always going to be a high friction area, and we do have quite good results from that. So these are a couple of the studies that have been done in radiation treatment unit here at the Royal Brisbane. We did do a double-blind randomised control trial looking at Mugu Udder cream versus a sorbolene cream or an aqueous here. And then we've also got the single-blind randomised control trial for the Strata XRT silicone gel. So we do like water-based products because they're easily absorbed and there's no residual oil remaining on the skin. We advise against vitamin E moisturisers because, and there is that antioxidant component to them. No glycerol, no extra perfumes, and we do advise no deodorants on breasts and lungs. So now we're starting to get a little bit further into the treatment. So you get that drying and shedding and the deepening of the dry desquamation. So you can see on the breast there, it's also probably a little bit of a mixed fungal reaction. So sometimes patients will present and when you're getting a patchy desquamation over the breast tissue, there is likeliness that there is some kind of mixed infection with that. So we do get the doctors to come and have a look at that, and then we would either continue with your strata or potentially if the patient was really uncomfortable from the drying and shedding. So with the nose, we would do a day where we do a Prontosan soak 15-minute gauze on, say, the patient's nose to help remove that dried desquamation skin buildup. Or we sometimes just do a little spot on of your Intrasite and let that soak in and then use normal saline and cleanse that away, and that's enough to take that tissue away, and then they're right to go back to their normal products. So now you're getting to a CTCAE where the body's unable to keep up with that drying and shedding of the skin cells, and so you start getting moist wound environments. They are related with pain. A lot of patients report that they feel like it's like carpet burn, that very nerve ending pain, and so they do get a slough buildup of those dead tissues. So for us, it's important to minimise pain and help autolytically debride them. So we use hydrogels such as the Intrasite, Atroman, just as a secondary dressing, and Combine just to help humidify that Intrasite because we're an outpatient setting. We only do a dressing once a day for that patient, and potentially we might start them on some antibiotics. Okay, and then CTCAE4, these are some of our complex or more complex patients. Often enough, when you get a CTCAE4, they're a fungating tumour, so they are considered often palliative in nature when we're treating them. So the fungating breast, the bulbous yellow tissue, you can usually smell them before you see them, the patients, which is really unfortunate. So I think I'll go into the fungating management a little bit later on. But really what we need to do is make the patient as comfortable as we can with the wound care for these patients. Okay, so we do get fungating, we get necrosis, ulceration, And then, you know, we've got a large melanoma fungating on the patient's back there. So we do undertake comprehensive wound assessments, so really listening to what the patient finds the most distressing in regards to their wound overall. We do liaise with the Skin Integrity Unit here at the Royal Brisbane, and we do initiate discharge planning for these patients. Post-treatment skincare, however many weeks of treatment, active treatment the patient has had, that's roughly the same healing on after they've finished. So we get the patients to continue with, if they haven't had broken skin, we get them to continue with their Strata XRT, and we're kind of staying away now from your pseudo-creams. We used to advise of pseudo-cream, it's a zinc oxide paste, because a lot of our patients were coming down from rural and remote areas. They didn't have the resources or being able to get the products that they need, and they would also go back out onto the farms traditionally and become quite sunburnt again. So we kind of felt a few years ago that the pseudo-cream would be good at, you know, helping to prevent infection and providing some kind of protection from extra skin, radiation skin exposure. So this is a good example of radiation skin reaction healing. So we do have a grade 3 radiation and skin reaction in image A. Image B is 2 weeks post, and then image C would be 6 weeks post-treatment. I think some of my favourite wound care to do would be your fungating wound management. Often these patients are brought in from the community where they can be quite resistive to changes in their wound care practices, or they can be quite ashamed of the wound. Sometimes they hide the wound or the fungating mass from their families or carers, and then they often come in because they've had a big bleed in that area. So sometimes it's, trying to build rapport for a few days with them before we initiate any changes to their wound care practices. And when we have patients that come in with fungating masses, often they're highly vascular as well. So we do have issues with exsanguination, so bleeding out through the fungating mass. They're also malodorous, they ooze a lot and things like that. So a lot of the time we sit down with the patient and the family and we say, what's your most distressing symptom from these wounds? And they say, the smell is usually number one, and the fact that they're leaking all over their clothes, all over their bed. So we do sit down with them, and we usually, we'll draw up a wound care plan for them. And we have gone towards your sore backs because we know that these wounds can be quite painful. So we find a sore back will manage not only the bacteria in the wound, but they'll also manage the odour. And, it's something that we can kind of set and forget. We can put it on, leave it on for 7 days and just change the outer dressing. So it really reduces that distress that the patient can experience from that. Thank you.
So do we have any questions from the audience? So Jennifer, do you have any suggestions for odour control?
Would that be when they're fungating or just throughout? Yeah. We do use Sorbact to manage that. Sometimes in the community, if people can't get Sorbact, they do still use crushed flagyl. We don't find it to be that effective, so here we use Sorbact for those products.
What about charcoal? The charcoal impregnated dressings?
We would be unable to treat through them, so we do know with a single layer of Sorbact we treat through those products. Potentially in the community, once they're not actively having treatment, they could use those products.
Well, in the community too, you could use Flamazine to reduce your bacterial load, to help with odour as well, because I've certainly done that.
Yeah. So we have to give the patients a break from active treatment if we put them on flamazine. So often if they get a grade 4 skin reaction, so that real ulceration of those tissues, we'll give them a weekend break, put them on flamazine, and then bring them back in for a skin assessment as to whether we can proceed with active treatment.
Yeah, flamazine has other uses other than just to using for burns or leg ulcers. It's got all sorts of things in it. Have we got any questions from committee? We're just getting a question coming through. Oh, it's loading. We love technology. But it lets us do these presentations and talk to 50 people around the country. So that's a good thing. Have we got it? No, we've lost that question. Have we got any other questions from the audience? Hang on.
I just had a wee question about Strata. You said that you recommend, the feedback. You recommend that if a patient is coming in, say they've got 30 fractions, so they're in for 6 weeks,
Yep.
you are recommending Strata for 6 weeks after that, are you? Or do you recommend it for a slightly shorter period?
So when we did the study, we looked at the cost effectiveness as well as how many tubes a patient would go through. So as an average, most patients would go through 2 tubes throughout their treatment. And what we really want to do is look at the active treatment phase. So we provide 2 full tubes to patients while they're on treatment. Some patients have some left over and they continue to use that afterwards. If they run out 3 weeks into the 6 weeks healing phase, they can swap over to a sorboline or something else.
Cool. Thank you. I just thought it was interesting, the 6 weeks post concept.
Which is probably the part where patients, because on their first day we sit them down, we provide them with the skincare that's appropriate to them. We do some education with them, and so part of that education is letting the patient know that yes, you will develop a skin reaction from, it usually starts from week 3 onwards. However, the way that it manifests is the same way that it subsides. So a lot of people or patients come and they think from the last day that's it, but you're still dealing with a lot of those side effects, and so they do go back out into regional and remote areas, and so there's lots of community GP practices that help manage these patients for us, which is good.
Thank you.
Not a problem.
Jennifer, is there any recommendations for people having oral reactions, so mouth ulcers, blistering, that kind of thing, while they're having their radiotherapy?
Yes, so we do provide these patients with oral cares. So we do use sodium bicarbonate mouthwashes or normal saline, and they usually alternate between those. And we know that the most important thing is keeping your mouth oral thrush free. So that's regular assessments of their mucosa, as well as artificial salivas. We know that keeping the environment nice and moist is the best thing for it. So we provide them with artificial salivas, and we do use a lot of your biotine products. There's also your discs that adhere to your mucosa in your mouth, and they're a slow release moisturising agent now. But there is a national cancer care network called EviQ. So if you ever had any questions about side effects of chemo treatments or radiation, you can access EviQ, and you can read everything that you need, as well as or the frameworks that we use to assess and manage these patients and their side effects.
How do you spell EVQ, just for people to do a search for it?
Yeah, it's EVIQ.
We do have one question online here. The question is there any type of financial support available to patients for the management of malignant wounds in the community and to source wound management products relating to their radiotherapy?
Yeah, so that's a good question. That really depends on the district, so the state that you're under, and, you know, whether you can get that patient to be deemed as palliative, so, you know, within the last 3 months of life. Once they're deemed palliative, there's a lot more services that the government does fund. However, at the moment, if they were under 65 and probably in that not palliative phase, they kind of fall out of a lot of funding. So here at the Royal, we do use I don't know if it's still called the post-acute wound service, which will manage patients' wounds for up to 2 weeks, and then we do have to apply for divisional funding within Metro North to extend that, and we do that for a lot of our patients. But unfortunately, at the moment, if they're not palliative or terminal and they're under 65, there's not really that much. It would depend on what your individual health service provides the patient.
Can be a bit challenging sometimes. Yeah. It's a long journey too. Okay, I think that's all of our questions. So thank you very much, Jennifer.
Thank you very much
your
for having me
time
here.
and sharing your knowledge with us. And it's something that I'm sure all of us will end up coming across in practice somewhere along the line during our wound healing careers. Thank you very much.
Thank you.
So just give us a minute to deal with technology. We'll be ready in a moment. Okay, so hello again. And now we're moving on to our second speaker this evening. So our second speaker is Professor Bridget Gillespie, and Bridget's topic this evening is interventions to reduce surgical site infections. Show me the evidence. We all like evidence. Bridget is a conjoint professor of patient safety in nursing at the Gold Coast University Hospital and at the Griffith School of Nursing and Midwifery Gold Coast campus. Her research focuses on 2 important areas of patient safety, that is compromised skin integrity and teamwork and communication in surgery. Bridget has authored over 170 peer-reviewed publications and 5 book chapters. Goodness me, she sounds like a busy woman. She's won $10 million worth in competitive research grants, including 6 NH and MRC grants. Very impressive. So we welcome Bridget to share her wealth of knowledge and to show us some evidence about how to reduce our surgical site infections. Thank you, Bridget.
Well, thank you. I'd just like to thank Kathleen and the organisers for inviting me here today, or tonight. Does this work? Maybe, does this work? Possibly. Okay, great. So I have to put a caveat in it. I don't have any gory pictures to show you, and I know I'm an OR nurse, and I used to look into, you know, bodies, but wounds I'm not, you know, so it's not, I won't be showing you any tonight, but what I will, yeah, that's, oops. Try that again. Right.
So the button's actually that big bit there. So that's
Okay, thank you. So what I will be talking about tonight is giving you a little bit of information about the incidence, prevalence and costs of wound complications, talking about where to find the evidence. Probably most of you know where to find the evidence, but just as maybe a quick recap, and the sources of evidence. Some of the interventions that have been recommended for surgical care. I'll present a series of studies that I've led with my group, looking at surgical wounds particularly. I'll be talking a little bit about choosing wisely and the dilemma that clinicians face in practice where there is a dearth of evidence. And I want to give a plug for our new NHMRC Wiser Wounds Care Centre of Research Excellence, and just to let you guys know it's on the map, and if you want to talk to any of us about that. So you probably know there's a lot of surgeries done around the world, around 4,500 for every 100,000 population occur for around 22 people, which is a lot. Surgical wounds are the most common wounds in hospital settings, and the risk factors associated with surgery include obviously the type of procedure, the site, the presence of drains, and wound classification, which I'm sure you're all aware of. The incidence of surgical site infection varies, and it depends on what literature you read, and there's really not actually a lot of good prevalence data, even in the Australian context, but it varies from around 1.5% up to 40%, and that's in surgeries like colorectal, where you would expect the infection rates to be higher. But they are the most preventable surgical site infections. And 1 patient in 4 will develop a post-operative wound complication within 14 days of hospital discharge. The literature says between 10 to 14 days. It depends on the type of wound and where the patient is, and a whole lot of other factors. Surgical site complications account for around 4% of total healthcare costs, and this cost is rising. I don't think we actually capture it very well. I'm not sure about all the data that we get from that to actually capture that accurately. Some estimates say that it costs it's around $30,000 per surgical site infection. Non-healing wounds increase mortality risk and reduce patients' function and their quality of life, and there's quite a lot of literature emerging around surgical wounds and chronic surgical wounds. We think about acute wounds lasting up to 4 to 6 weeks, but actually lasting longer than that. Failure to heal due to patient characteristics and comorbidities such as wound dehiscence, and wound dehiscence is quite serious. It's less than 1%. We've just done a systematic review, and we've included about 20 studies, and it suggests that it's less than 1% or around just under 1%. Surgical site infection can be up to about 12-14%. So it really is important to apply evidence-based strategies in clinical practice that contribute to better patient outcomes. So where is the evidence? Most of you know and maybe use the clinical practice guidelines. I've just put this one up. This is one that the WHO that was published in 2016. We look to the clinical practice guidelines. It gives us a summary of the current medical knowledge in the area, weighs up the benefits and harms of procedures, and gives specific recommendations based on this information. They offer guidance in the standardisation of care and to improve the allocation and use of the finite healthcare resources, which are increasingly becoming more finite, and reducing waste, things that we don't necessarily need to do, we've done in the past, but perhaps don't need to do anymore. There's a potential for clinical practice guidelines to enhance practice and improve care, but this really is dependent on their quality. So we wanted to know, one of the things that we wanted to know was what is the quality of the surgical site infection prevention guidelines. So we did a systematic review to find that out. And we asked what was the quality and the strength of the recommendations of these clinical practice guidelines and how have these guidelines been revised, updated, and have they improved over time? So we did a search and used a number of databases, as you can see here. We undertook independent data extraction and quality appraisal. We used a tool called the Appraisal of Guidelines Research and Evaluation, called the AGREE2 tool, and it has 6 domains, and we scored each guideline that was included against these 6 domains. So scope and purpose, stakeholder involvement, clarity of the presentation of the guideline as a whole, applicability, and editorial independence. In the final analysis, we had 15 documents, 6 complete clinical practice guidelines, 3 updates and 6 additional documents. The dates were from 1999, which was when the CDC guidelines came out, to 2018. So on the whole, domain scores were higher across all guidelines in terms of scope and purpose, clarity, whether people could follow it, the sections were clearly delineated, rigour of development and editorial independence. Scores were lower in stakeholder involvement, and perhaps a lot of you would now be hearing, about the notion of consumer involvement and patient participation in treatment. That's very important, and it's really important when we think about how we develop our clinical practice guidelines and kind of putting the patient at the centre of that. Most of the guidelines we looked at, and this was in 2018, lacked that stakeholder involvement. Also lacked applicability, which is like, how are they implemented? How can they be tailored to the context? There was limited consideration in terms of resource and lack of economic evaluations to inform those guidelines. So economic evaluations inform decision-making around the resources that we use in healthcare. Very, very important, and should be done alongside any randomised controlled trial. Most clinical practice guidelines were evaluated as recommended. There were a few that we didn't recommend. They had low scores across most of these 6 domains. There were several unresolved issues, a lack of robust evidence that underpinned a lot of the guidelines, and fewest recommendations in wound care, which perhaps may explain why there's such variation in practice in wound care. So where's the evidence? We wanted to have a look and see what systematic reviews were out there. Now, Cochrane reviews are the gold standard if you're thinking about doing a systematic review. I've done several now with Cochrane, and they're very, very rigorous. So we thought we'd just look at these Cochrane reviews and evaluate recommendations for nursing practice and research from these reviews about pre- and post-operative wound care interventions. So we went through, we used the PICO criteria, we used a tool called the measurement tool to assess systematic reviews. It was a kind of a checklist, and again we gave scores for each of the Cochrane reviews that were included. There was independent data extraction and quality appraisal. The dates of these Cochrane reviews, they were published between 2006 and 2018, and in all there were 22 Cochrane reviews, 11 in pre-op and 12 in post-op, but one actually included, so it's actually 23, but one actually included recommendations based on some pre-op and some post-op interventions. 14 of those 22 reviews made at least one specific recommendation to undertake a practice. 2 of those 22 reviews made at least one specific recommendation not to undertake a practice. These were some of the things that these Cochrane reviews, these pre-operative and post-operative interventions that were reviewed, and the authors of the Cochrane reviews had actually gathered the evidence from studies that looked at the effectiveness of these types of strategies in preventing surgical site infections. So I think some of them are a bit passé, really, aren't they? But this is what some of the earlier Cochrane reviews had looked at: hair removal and shaving and bathing and that kind of thing. what we found was that the quality of the Cochrane reviews had improved over time, but the quality of the studies within the Cochrane reviews actually varied. The recommendations to do something or not to do something focused mainly on reducing side effects of harm. Many recommendations were tentative or conditional because of the methodological limitations in the evidence base. So a lot of these studies were small studies. They didn't really tell us very much. Taken by itself, it might have been an RCT. Taken by itself may have had a sample of 100. That's not going to tell us as much as combining several studies to give us a bigger sample size to see if we can truly find an effect. Despite the desire to use evidence-based practice, contextual constraints, uncertainty in the evidence base, and prior clinical experience with clinical decisions often are based on people using what they know, their internalised rule of thumb for different things. And that's another thing that came out of some of these Cochrane reviews. So, internalised decisions. One of the studies that we did was to actually ask nurses and wound care professionals how they made decisions about the way they provided their wound care. We used a grounded theory approach, so we looked at as based on symbolic interactionalism. We looked at the processes around the care and the decisions they made to provide that care. We interviewed 20 people from nursing, medicine and infection control. We did semi-structured interviews and recorded them. We used a constant comparative analysis. The main category, the core category of this grounded theory study was balancing practice-based knowledge with evidence-based knowledge. And this is just really, I think a picture says 1,000 words. So if you look at the pyramid, you can see on the bottom, the basis for anything is using the evidence base. And our participants talked about using biased information, selecting products based on branding, what they felt comfortable with, which is absolutely understandable, and we all do that. Adhering to best practices, but challenging entrenched practices that weren't based on evidence. So that certainly that first category was something that everyone talked about, the information that they had available. And then it was using a consistent approach to wound assessment, balancing costs, being consistent, using innovative technologies. You know, there's been a lot of innovation in this space. Sharing specialist knowledge and understanding the goals of treatment. And the icing on the cake was actually using a multidisciplinary and holistic approach to treating the wounds. So advocating for patients, treating patients like individuals, collaborating with others and valuing others' expertise. So wound care is often considered a nursing activity, but it's actually an interdisciplinary, multidisciplinary activity, and that certainly came out in what participants said. Then we thought, you know, look, we've asked people what they do, let's go and observe what they do. So the next study that we did in a series of studies was to describe and compare post-operative wound practices across 2 hospitals. So we used a prospective comparative design, 17 wards, consecutive and convenient sampling of nurses and patients. I'm not going to present the nursing data tonight, but we used structured observations of wound care episodes, and also we audited the medical charts. The data included patients' demographics, surgical wound characteristics. We also looked at ORMUS data as well, and we used descriptive and inferential statistics. In all, we looked at 257 surgical patients or episodes of surgical care across these 2 hospitals. Most patients were males, just over 50%, and most had elective surgery. 7 received post-operative, 71 out of the 257 received some sort of post-operative wound care education. There were significant differences in hand hygiene with the use of clean gloves in a non-touch technique. So just you can see here, if you look what types of things that we observe, the use of preemptive analgesia, the use of PPE, hand washing before dressing change. You can see that's a difference between the two hospital sites, and the use of clean gloves and a non-touch technique. So all of these other ones were non-significant between the two hospitals. We were looking at the variation in practices to see if there was variation in practice. So you can ask people, but it's not until you actually observe, and we did this very rigorously. We had used a tool that was developed through one of my honours students' work, and we had kind of perfected this tool and used it as an observational tool, and have done inter-rater reliability on it. So, and it was drawn from the literature from the guidelines. We also did an audit of documentation, and you can see here, if you have a look at the two hospitals, there's differences all the way through. One hospital actually used integrated IEMR and the other didn't. So perhaps that is one of the reasons for these significant differences. But there is still a lot of inconsistency in how things are documented in wound care. So while the patient cohorts were similar in relation to some of those important characteristics like gender and age, length of surgical procedure, there was reasonable consistency except for hand washing and using a clean glove and a non-touch technique when doing dressings. There were variations in healthcare contexts, particularly with documentation, and that's likely because of the different documentation systems that were used in each hospital. Historically based practices in the absence of robust evidence. So, you know, sometimes we would observe an aseptic technique being used. The benefits, the literature talks about the benefits of using aseptic technique in the post-operative period are questionable, and there's not a lot of evidence to support it, whereas using a clean technique is probably all that's needed in the post-operative period. But there's lots of evidence around wound care, but the quality of the evidence, generally speaking, is quite scarce. Now, I'm sure our partners, our trade partners outside, showed us all of these wonderful technologies, and one of them is negative pressure wound therapy, and it's really revolutionised the way that particularly chronic wounds are treated, but also increasingly now being used in surgical wounds. So you're probably all familiar, and much of this information you're all familiar with. In terms of what the device exerts, around 70, I was speaking to someone tonight, they said 70 to 125, depending on what literature you read or what type of device you use. The mechanism of action is believed to reduce bacterial entry into the wound while removing tissue edema and stimulating granulation. I wanted to mention this because we undertook a trial to look at the use of negative pressure wound therapy in obese women undergoing elective and semi-urgent caesarean section. We just found out today that our paper for this trial has been accepted in BMJ. This is actually just the protocol that we had published several years ago, so it's really nice to know that it will be published very soon. It was a trial that was funded by the NHMRC for $2.3 million. So it was a very, very expensive trial. It took 5 years. We had 2,035 women in the sample, BMI of 30 or greater. We used the PICO dressing. We had done a previous product evaluation using 3 types of dressings, and we asked the doctors, the nurses and the patients what they preferred. And the patients preferred this dressing because this device because it was small and it was very compact. So that's what we went with this trial. We started it in 2015. So our primary outcome was the 30-day cumulative incidence of surgical site infection. Secondary outcomes included the type. We also looked at hospital length of stay and other complications. We did an economic evaluation alongside this trial. So we collected data at different time points, at 36 weeks, the day of caesarean section, 2 days post-op, and then 4 weeks at weekly periods thereafter. We also did a 30-day chart audit. In terms of blinding, our research nurses, patients, clinicians could not be blinded because of the obvious nature of the intervention, but we had independent outcome assessors who were blinded, and we had 3 outcome assessors. We had 2 that looked at all of the data, and then where there was a discrepancy, we had a 3rd outcome assessor who adjudicated that discrepancy. And we used intention to treat analysis, which means that all patients who are randomised to the group they are allocated to are then analysed according to that group allocation, even if they accidentally get another dressing. And we did a whole lot of comparative analysis using some inferential statistics that you can see here. We also used a multivariate model to see what some of the prognostic factors were that may have a bearing on patients getting a surgical site infection, and these are probably, you probably will be able to name them without even looking at the literature, but BMI, age, diabetes, smoking, rupture of membranes, parity, length of procedure. So, across the entire sample of 2,035, the SSI rate was 9%, which is pretty good, pretty low actually, certainly lower than we thought it would be. Across the negative pressure group, it was 7% versus 10% in the standard dressing group. There was a 24% absolute reduction in surgical site infection rates among women in the negative pressure group versus women in the control group. It wasn't statistically significant, but we had done a series of different types of analyses, different analytic scenarios, but it was certainly edging along statistical significance. Our multivariate model also suggested a favouring effect towards using negative pressure, and it came out in our model as being significant. There were no group differences in terms of complication rates. There was a 72% increase in blistering rates among women in the negative pressure group versus women in the control group. So that means that could be due to a number of different factors. Certainly the dressings were applied in the same way in the operating room and applied according to the manufacturer's instructions, recommendations. Rates of adverse events were less than 1% and no differences among groups. So yes, the baseline infection rates was lower than we had estimated and used as part of our sample size calculation, so possibly our sample size wasn't large enough to detect a true difference. Across hospital sites, women in both groups were definitely given a high standard of care, so that's something that, you know, the hospitals can certainly be proud of. You know, a standard of care that is reflective of what we see in the clinical practice guidelines. We used a conservative approach, so we assumed that women who had missing data did not go back to the hospital, and so we recorded that they did not have any infection. So we didn't say they had, we said they hadn't had any infection. There was only 24 women that we couldn't get data on at the follow-up of 30 days. But we assumed that those women didn't have an infection. However, we did do other analyses where we based the assumption on those women, and we said they did get an SSI. And when we did that, it became statistically significant. When we looked back at the model, it was statistically significant. The group allocation was statistically significant and supporting the use of negative pressure, the negative pressure group. So while the differences weren't in our primary analysis, our a priori analysis weren't statistically significant, they were, coming towards statistical significance, and actually may underestimate, so both things, may underestimate the effect that negative pressure has in this population. When we did the analysis the other way, we could possibly be overestimating the effect that negative pressure has. When we put our trial results in a meta-analysis alongside other trials that have been done, there is a reduction of around 27% in the patients who receive negative pressure. So when you think of a meta-analysis, that's level A1 evidence. So that's something that clinicians should actually take some notice of. We did an economic evaluation. Now, with that, we have to dig a bit deeper, but at the moment, the results of that, which I haven't presented here, the results suggest there's a 20% economic benefit using negative pressure wound therapy. But so decision makers have to make a balance, they have to make a call about what, and maybe, we probably need to delve a bit deeper into that data to see what else we collected, things on resource usage, length of stay, all of those sorts of things that you do collect data on to see what the costings would be, dressing use, etc., going back to the GP, all of that. So choosing wisely, we have all of these wonderful technologies, all of these things at our disposal. There is still a lot of practices that are undertaken that are perhaps not have strong evidence, but clinicians still need to make a decision in the face of uncertainty. And it's difficult sometimes to establish what is, high value care from low value care when the evidence is limited. Where there is clear evidence, clinical guidelines need to provide clinicians and guide clinicians in terms of what they should be doing. Because sometimes clinicians just want to know, should I be doing this? And when a decision is made not to do something, it's often around that whole notion of causing harm. And that's, the benefit versus the burden, the harm done. So people are very conservative, and that's rightly so. But again, I go back to the evidence, and for a lot of things that we do, there is very limited practice, very limited evidence. So there is a dilemma, and how do you decide? Evidence-based practice looks at the evidence, looks at the clinician, and looks at the patient. Always the patient should be there somewhere. You've probably all heard of Choosing Wisely campaigns to increase awareness of low-value care. And something like 10 to 30% of all healthcare practices have little or no benefit to patients. The use of evidence-based practice may help to achieve a more consistent approach, but they need to be adapted to the clinical context. And, at the end of the day, not all recommendations are based on level A evidence or level 1 evidence. And you just need to know, okay, well, is it something that's a clinical judgment in the end? But I guess importantly, wound care is not just the nurse's responsibility, it's everyone's responsibility. So working in teams is very important to help make those decisions in the face of uncertainty, but also including patients in those decisions. These are the references that I've used. I just wanted to quickly give our Centre of Research Excellence a plug. It's called Wiser Wounds. Some of these people's names you probably do recognise. They're big in pressure injuries or intravascular access. And these are our aims: to generate new knowledge, effective transfer of research outcomes into policy, and that's around implementation, to develop the next workforce of medical and health researchers, and collaborate with people, locally, nationally and internationally. Our focuses are pressure injuries, surgical wounds and intravascular devices. And the types of studies we do are observational, clinical trials and knowledge translation around implementation and de-implementation. So if you want to know any more, just flick me an email or flick Wendy an email. So thank you very much.
Very interesting presentation. Thank you, Bridget. As a wound nurse and a surgical nurse, I can certainly identify with many of the points that you have made there. I was quite surprised for you to say that theoretically there's 1 in 4 surgical wounds develop an infection. But once the patient leaves the acute setting, unless it's a significant problem, you don't actually see it. So certainly a percentage are managed by themselves and a percentage are managed by the GP. And exactly as you were saying with your caesarean group, you presume that they don't have a problem because they haven't come back. But in fact, there's a significant percentage of people who do actually struggle with a draining hematoma or seroma or whatever, that is being managed by their local GP practice or by their friend next door who's a nurse, or by some way by Dr. Google, rather than coming back to the hospital, particularly if they're not local, particularly perhaps if they've come into the city, into a private place or something, and then they've gone hundreds of K back home again. You're not going to see those people again. But perhaps with the emergence of telehealth, we might see a little bit more evidence now, because it is so much easier to reconnect with the patient again.
We did have, certainly one of the limitations to our trial was that we didn't have any access to GP data. And that was we tried to get access, we tried to link in with the GPs. We did a pilot study and we had no luck at all. So we had to rely on these women coming back to the hospital. Now, they may have come back, and some of them did, obviously, but, you know, how many women would we have missed? And we relied on their weekly reporting of their symptoms, which we've used before very successfully in other studies. And we know that women can, patients can, if the language is in lay terms and they understand what you're asking, they can report that accurately. But we didn't have. That was one of the limitations. We, couldn't, unfortunately. So there would have been infections that we missed. Most definitely. So yeah, it's interesting. We just I think it would be good for hospitals and GPs to link better in the community. I don't know how well that happens.
Perhaps with the introduction of the My Health Record being a little bit more comprehensive, that will give us access to see what's happened before, perhaps look at a surgical report if someone's come from interstate and what operation did they actually have. You can actually, on the My Health Record, look up, if it's a hospital that has electronic record, you can look up the operation notes themselves and not have to wait for them to scan them through and so fax them through to you. So that's actually a benefit of the My Health Record, to actually be able to see that electronic data which is there, and trace the patient's journey before you receive them. And the use of negative pressure, certainly, I work in an acute surgical and orthopaedic ward, so we do colorectal, and we also get all the infected wounds for, like, Caesar ladies readmitted because they don't go back to maternity. Anything that's a dirty wound doesn't go back to the women's and children's, it comes to surgical ward. So there certainly is, to some degree, an increase in the use of prophylactic negative pressure in the higher risk patients, and I'd say probably over the last 12 months, to see a change in surgeons, some doing it, some doing whatever their normal practice is. But the thing about using negative pressure in your Caesar ladies is that they're the healthiest bunch of patients that you're going to get. They don't have long, millions of other comorbidities that everybody else does. So if they need it, then there's a whole pile of other people worse off than them that certainly probably do.
I think with this group, we did look at a group, we looked at obesity as classified as a BMI of 30 or greater. And so those women did have more comorbidities than women without that at their age, yes, I think I mean, I think we can say that there's certainly some strong evidence to say that using negative pressure in this group is beneficial, is definitely beneficial. It's just now whether it's cost effective and drilling down into the data to see, well, you know, looking at, we've taken a helicopter view with the cost effectiveness, but drilling down in the data to see whether it really is cost effective. And we might need to follow these women through or follow patients through to find that out, to really get a good idea.
And who is it cost effective to? Is it cost effective to the primary facility that is not going to have them readmitted? Or is the cost just being moved on to the GP practice or the patient's purse to deal with whatever it is that is the issue that they have? Then you have the cost issues of if the wound that they have is a problem caused by an iatrogenic issue, perhaps a surgical complication as in an injury, a complication from their surgery, or a hospital-acquired pressure injury. Now, where does the cost lie? Wasn't the patient's fault to get their hospital-acquired pressure injury, specifically by most of their actions. You know, what is the true cost of these things is very complicated. You know, the cost for the inpatient, the cost of community, cost for the patient not being able to go back to work, the cost in, you know, relationship and household issues, in how many times they have to go to the GP. There's no simple answer, unfortunately.
With economic evaluations, they look at it usually from the perspective of the health service. So that was the perspective that we looked at it from. So we didn't look at it from the perspective of the patient, but from the perspective, and I suppose decision makers want to see, okay, how is this going to save us some dollars? And so that's why a lot of economic evaluations are done from the perspective of the health organisation.
We have a question online. Thanks, Bridget. In the dressing trial, what at-risk criteria was used for interventions? I'm interested in the evidence for the prophylactic negative pressure therapy in the risk groups.
So we looked at the prognostic factors in terms of whether those factors would predispose this cohort to developing a surgical site infection or wound complication. So those factors we identified through the literature, and we looked at, we also asked obstetricians. We had 3 obstetricians on our team from the various hospitals. So those were the risk factors that we looked at in terms of, we looked at it from the perspective of wound complications and that risk factors that may well be across a lot of populations, but also specific to the population that we looked at. I hope I've answered that question.
Yes, thank you. Good to see that you actually had some obstetricians, surgeons actually have some engagement on their part, some uptake and some motivation to actually participate and get some real evidence rather than just, you know, this is what our practice does, or, you know, anecdotally, this is what I've done for 20 years.
And, you know, that's what actually motivated us to do this, because there was a lot of that kind of thing happening. Well, if a woman's got a BMI, I'm going to put a dressing on, I'm going to put a negative pressure dressing on. Well, they can't be, and you can't have that patient in our trial because we need to be able to randomise them. But that was the kind of rule of thumb that I was talking about before, that people have, you know, oh, I know that it works, or this is, you know, but I think I'm hoping that the results of this trial do kind of make people think about it more and look at, and you know, because it was a very rigorously done trial. And I mean, there, as I say, when you put it in a meta-analysis and you combine it with all the other trials that have been done, there's certainly a significant reduction. And I think that, you know, then you've got to balance up the blistering. Okay, well, okay, do I want a couple of blisters, which I might get anyway with the dressing? You know, it might be a minor thing for a woman, but I think the other thing is important is to make sure that the woman or the patient is involved in that decision making, but they need to understand what the benefits, the risks, and, you know, the alternatives are. So,
Oh, thank you, Bridget, lovely talk. My quick question was, with this C-section study, you've always heard the story that multiple C-sections, there is a greater risk of a surgical breakdown because the site's already been 2 or 3 times, involved in a surgical repair. Oh, sorry about that. So Bridget, my question is, when we come to the C-section study and we're looking at ladies that might have had multiple C-sections in the area, was that taken into account that they would be a high risk because they've had 2 or 3 procedures before, or were most of your ladies first-time C-sections?
We had a mix of both. We looked at parity as a predictor. We didn't necessarily look at whether they had multiple C-sections. We haven't done a deep dive actually into that data to see if we look at that group of women that have had more than, say, 2 or more. There weren't that many of them, but we haven't actually taken a deep dive to look at whether, looking at how they got those that did and those that didn't get an SSI or some other wound complication. But that's a really good idea. You've given me an idea because we've got a lot of data.
Because I was just thinking along those lines, because that could be a requirement that if this was going to be your 2nd or your 3rd C-section, you may have had a breakdown on a previous one. You might be a person that's going to be recommended to have a negative pressure dressing put on to A, improve your healing, B, prevention, and get you through the repair. The other question I wanted to ask was, you said there was a post-operative length of time. What did you regard that as, in an acute through to a repair stage? Was it just 30 days? Or how did that work?
We use the CDC definition to look at these surgical wounds, and they're followed up for 30 days. So we looked at, wounds where there's a prosthetic or operations where there's a prosthesis involved can be followed up for 60 to 90 days. But we followed these women up for 30 days. And really, not just when they're discharged, because as we know, infections can develop long after discharge. Literature says somewhere between day 10 and 14. Of course, they can manifest before then, and some people don't leave the hospital. They have a prolonged length of stay because they develop an infection earlier than that. But most of these women had a mean length of stay, I think, about three days. And it wasn't picked up. But, we hope that if we follow them through for that 13 days, as the CDC recommends, we would pick it up. We would detect it if it happened.
Thank you for that. That was great.
Hi, Bridget. Thank you for your presentation. I was just curious if you had looked at or considering looking at wound dehiscence in the absence of wound infection in these patients, because apart from being quite an awful morbid condition in terms of disfigurement and scarring and discomfort, I could imagine there would be a whole lot more cost involved in then having to manage a wound and heal that, as opposed to an infection that didn't have a wound breakdown.
Look, we haven't really drilled down to the data that far. We did look at when we looked at the 30-day chart, and you'd look to see if there were any lab results that, by the definition, using the CDC definition. Again, we haven't done a deep dive to see if those women who developed dehiscence, and I think, I think there was only 1 or 2. But I'd have to go back and have a look. It was very, very, and the same with, deep and organ space infection. There were very few women, which is good. But we'd have that's a really good question.
If there's only 1 or 2, that's an amazing outcome for 2,000 cases, regardless of what standard treatment versus any other treatment.
I think because, and this is just my, I think because these women, and we documented the care that they got. We documented from when they came in to when they were discharged and what care they got after that, whether they'd spoken to their GP, etc. And you know, they got really good care. I mean, on the whole, they got really good care. That was reflective of best practice.
Well, it's great that all the women in the study had the opportunity to receive excellent care. You know, we're in a place, says something for our Australian system, that we have resources that people can actually tap into and access. And the issue of the blisters, it makes me wonder, because I see lots of blisters from dressings, you know, is it an allergy to the thing? Is it shear and friction? No, is it edema, stretch, you know, all those kinds of things. There's so many questions that we can ask in the wound world, and not one study is going to answer any of them.
Absolutely, and I think that as a woman, if you'd really have to sit down with your obstetrician and, yes, I mean, and look at your risk factors and then what they recommend based on the evidence, based on your risk factors. And whether blistering is something that women should definitely know that there's a risk of that. But does that risk, maybe getting a surgical site infection, actually outweighs that risk?
Any more questions for the audience? No? I think we've covered it. Thank you so much, Bridget. Excellent presentation. So just give us a moment while we deal with technology. Okay, so Convatec, one of our, is our major sponsor this evening. And this evening we have David Thomas, who is the medical sales specialist for Advanced Wound Care, and he would like to talk to us about their Aquacel AG surgical dressing. Thank you, David.
No worries. Well, my background basically is 30-something odd years in medical, 15 years in the Army as a combat advanced medic, and 20 years in theatres as a scout nurse and anaesthetic nurse. So I went to Convatec about 1.5 years ago, just before COVID, which was really handy. So Aquacel AG Surgical. People have heard of the hydrofibre dressing Aquacel. Aquacel then had Silver AG added to it. In America, they decided that they wanted those two particular products combined, and that's where the Aquacel AG Surgical product comes from. So the outside of the dressing is a post-operative dressing. It is waterproof, and it also helps with SSIs. There's 1 part per million of silver embedded into the dressing, and it stays within the dressing, killing any infections inside the wound and also around the wound itself. So SSIs are a financial burden on everyone, hospitals and patients. The infection rates were seen to decrease by 60 to 70%. And skin blistering was also reduced, being the Duoderm outside dressing. Once it's adhered to the skin, it was actually moving with the skin and not allowing any friction or any blistering under the skin. And also reduced any delayed discharges by 80%, so there was no infections or anything combined into that, and improved patient satisfaction by 10%. So it was comfortable. It's waterproof. The patient, as soon as they're back into the ward and they can get out of bed and safely have a shower, they can have a shower. With the dressing intact, it will not fall off. With the hydrofibre gel's on contact with exudate, and that allows for a moist wound healing environment, and also the silver to impregnate into the wound and kill any bacteria there. And it also is an active dressing. So it locks in, it responds. So it turns to a gel, responds to whatever the wound type is. So it doesn't matter how the surgeon's actually closed his wound, either by staples, sutures, glues, whatever you want to use. This will turn to a gel, and the gel will 100% contour to that wound. It also locks in, so it draws the exudate out of the wound and up into the dressing, and it vertically wicks the exudate into the dressing and locks it in. And again, micro contours to the wound again. One example of this, which is fairly close to, myself, my son, who's 28, stepped off his skateboard 4 weeks ago and completely shattered the top of his tibia. So he's got a grade 6 fracture with spider fractures all the way down through his tibial. He now has two 18-inch plates and approximately 30 screws holding his tibia together. He obviously had these dressings on, and there was no sign of infection, and they're just about healed now through the surgical sites. However, what I'm saying with this is he's 28, he's fit, he's young, he's healthy. He didn't need these dressings. He got them because I had them in the boot of my car, so I put them on. What I'm saying is these dressings are designed for a particular patient type. So this is an infill dressing between your gauze and fixable dressing, all the way up to your negative pressure dressings. This is the gap in between. So if you've got someone who's a type 2 diabetic who may have a wound breakdown, use one of these dressings. If you've got someone who's had a wound breakdown in the past but doesn't need negative pressure, so they're reasonably low BMI, use this dressing. Any questions on this? I'm very quick, sorry, I'm not going to stand here and talk.
So David, with the trend towards, particularly in the orthopaedic world, intact healing, as in trying to leave the dressing on for as long as possible. I know some of the surgeons are wanting the dressing to stay on at least 7 days, if not up to 14, to come back to clinic. How do you feel the reliability and durability of the wound? What is your recommendations for AG?
So the recommendation for this dressing is 7 days. It can stay on up to 14 days, and it's been shown the silver in the dressing will last for 14 days. So we've come across, I've spoken to a lot of orthopaedic surgeons and a lot of reconstructive breast surgeons, and everyone's different. It seems as though every surgeon you talk to is different in the way that they want their dressings held on and stays on. So some are 7, some are 10, some are 14. Where our dressings can stay on, as long as it's not full. And what we mean by full is 75% of the dressing you'll see strike through coming through with exudate through the dressing. 75% of the dressing's full, you take it off and change it, like any dressing.
Any questions from the floor? Thank you, David.
Thank you.
Certainly see an increased use of Aquacel AG surgical in the orthopaedic world, certainly in my workplace. It's become quite a regular thing to use. And yes, I think it is that stopgap between the basic dressing and the negative pressure at the other end of the patient scale. Blake? So here this evening at the Queensland event, we actually have the pleasure of the company of our CEO Blake, so we thought, seeing he was here, it'd be an opportunity for Blake to speak to the world, speak to the nation, the Wounds Australia members who are online. If you have any questions, please send them through. Here's Blake.
Cool. Well, thank you, everyone. I'll try and do better than Scott Morrison does with these things, right? So just a quick question. We've obviously got a pretty big conference coming up. I just wanted to know how many people here are registered to go to it? Okay, that's pretty good. Because does anybody know exactly how long it is? It's very exciting. Oh yeah, no, but before it's 40 hours, 4 minutes. 40 days, 4 hours and 26 minutes away. we have a countdown on the website, I'm cheating. But I guess what the point of just raising that is that it's actually a really great event. Obviously, we had to delay it from last year. We were going to have it in sunny Brisbane, face-to-face. A global pandemic kind of got in the way of that, really mucked with us. So it's now a virtual conference. It's happening in May. It's a 3-day great event. You get to watch it online, but it's more than just 3 days of staring at a computer screen. We're actually making the content available for 90 days following the event, so you don't have to sit there and spend 3 days in front of a computer, because who finds that fun? Just for everyone in the audience, no one's raising their hand. So we're aware that obviously you want to probably stream a couple of the really great speakers, a couple of the talks, but you can take sort of 3 months to get through the content, pace yourself through it, really absorb it. That's I guess the beauty about the online thing. Obviously we all wish it was completely face-to-face, but this is I guess the world we're finding ourselves in. But anyway, great event. If you haven't registered, please get your ticket now. We're very excited to have a lot of great sponsors supporting Wounds Australia through this difficult time, and the membership supporting Wounds Australia through attending the conference. Ideally, you'll learn a whole bunch out of it, and get out to the face-to-face events which are happening around the country, like this great one in Queensland tonight. Are there any questions that we can quickly answer? I can check online as well, because I'm doing the Slido thing behind the scenes. It's very technical. Although we do have a question for our previous presenters. How much does the dressing cost?
Depends who you work for.
It depends who you work for, right?
On average, 30 centimetres is about $40.
Okay, the answer is 30 centimetres is about $40. Perfect. Okay, so there you go. Look at that multitasking. There's no questions for me. So that's very easy. Look, thanks very much for having me. It obviously wasn't planned. I just slipped in here and Kathy was very kind to give me a few minutes on the floor. But I'll hand it back over to Kathy.
Hello again, and so now we come to our third presentation, our fifth presentation. Gee whiz, there we go. Our final presentation for the evening, and now we have Dr. Kathy Finlayson. So Kathy comes to us from the School of Nursing Centre for Healthcare Transformation at QUT. She's a long-standing member of the Queensland Wounds Australia Committee, and she was awarded a Fellow of Wounds Australia in 2018 at our last conference in recognition for her commitment to Wounds Australia. So she's well loved amongst the community in Wounds Australia. She's been researching with patients in chronic wounds and in evidence-based practice for over 25 years. So she's got lots of information in her brain. Welcome, Kathy. Thank you for sharing your time with us.
Thank you, and thank you for staying and listening. So I'm just going to have a very short presentation. We thought it might be a really useful idea just to actually remind ourselves or have a quick update of the best evidence that we have on surgical wound management. And we've also already heard a great presentation from Bridget on how wonky some of that evidence is. And you might be surprised when we go through these slides how little I have up here, which gives us something to work from in the future. Okay, so I've just got to work out how to move the slides. Yep, okay. So a quick 10-minute talk really about what do we actually know at the moment about surgical wound management by looking at a summary of our evidence-based guidelines and also at some recent systematic reviews or big studies. So this is actually coming from the Champions for Skin Integrity project, and some of you may have been involved in this or be aware of it, but the Champions for Skin Integrity model is one that we've been running now for over 10 years. It's a model of how to get our best practice into practice, actually to help health professionals and consumers basically increase our knowledge of and a range of strategies to increase our uptake of best practice. And we've trialled it in a range of settings. We've trialled it in aged care, we've trialled it in primary health networks, in acute care and transitional care as well. And in all of those settings, we've actually had really positive outcomes with decreased prevalence of wounds, decreased severity of wounds, and also increased uptake of best practice. And one small part of that model of care is a set of resources, why I've said it's based on the Champions for Skin Integrity resources. So these resources are a way of summarising what we do. I think this is our third version at the moment, is go through and have a look at what evidence is out there, both in systematic reviews and in evidence-based guidelines, summarise the individual recommendations, so the prime recommendations, and collate them and put them together in a summary of evidence-based guidelines. And then you might have noticed in Bridget's presentation, she noted it's difficult with each one of those guidelines, which are all about 200 pages each. They often use completely different rating systems for the levels, so we re-rate them according to one rating system. At the moment, we're using the NHMRC level of rating, so that people can look at each individual recommendation, have a look at the level of evidence. From this, we base a whole range of other resources for client education and for shorter brochures for health professionals, flow charts, etc. Because we noticed that most health professionals that we consulted didn't even want to read a 1 or 2 page summary of evidence-based guidelines. We need short and sharp. So it's a set of resources really just to be able to help us see something quickly when you want to look it up, to be able to look at the level of evidence for that and to see where, if you need to look at that further, the references are all there. Okay. So all our CSI resources are laid out under assessment, management and prevention, mainly because that's the way my brain works and it's simple. So if we have a quick look at primary evidence on assessment, did I go, wait a minute, did I skip one? I did. Most guidelines and best practice statements or consensus statement will recommend that we do a holistic assessment. So this is, logical. We know the importance of this to make sure that we're including both a physical and medical, a nutrition assessment, a psychosocial assessment, and pain assessment and treatments, so that we can actually have a pretty good idea of what risk factors that patient might have. It's also very strongly recommended in most guidelines that we use a standardised wound assessment tool and a risk assessment tool, although there is no standardised risk assessment tool actually recommended. So if I ask you, does anybody use one in their practice, the surgical nurses in the room? Risk assessment tool? Yes, to be able to really identify the level of risk of your patient that's coming in for surgery. I think probably the most commonly used one I've ever seen is the asepsis tool. Has anybody seen that? So, which really just highlights risk factors for surgical site infection. So yeah, so we use it, might be an area to think about going forward. So, and then of course it's recommended we obviously need to reassess regularly in order to be able to determine progress in healing. And of course it would be ideal if we had a validated tool to be able to do that with. So what the best evidence we have with assessment is actually a fairly good knowledge. There have been many, many studies on risk factors. And I've got just 2 slides of them here with the commonest ones which have been frequently found in most reviews. And that's, the older we get, the higher risk. High BMI patients are at greater risk. Patients with malnutrition issues, greater risk. Steroids or immunosuppressants, we know, are at higher risk. And the type of wound, as has already been raised. So if you've got bowel surgery, orthopaedic, if we've got contaminated wounds from trauma, we know they're at higher risk. Other wellness factors are smoking, diabetes mellitus, or other illnesses which cause problems. Radiotherapy within 90 days of surgery. We also know, and we've had a great talk here today on the impact of radiotherapy on healing and also skin damage. Funnily enough, longer pre-op length of stay, which generally correlates to the severity of comorbidities and health problems that a patient has. And we know that if they're under anaesthetic for a long time, longer duration of procedure, they're at higher risk. Just management. So that's basically all our evidence we've got on assessment is a knowledge of risk factors, and we possibly should put them all together and develop a rating system. But management. So it's still recommended, although there is little evidence, as shown before, on how much we need it, it's still recommended to use an aseptic technique to remove surgical dressings. And some guidelines have suggested just for the first 48 hours. It's almost like they're not game to, let it go, just for the first 48 hours, use a non-touch aseptic technique to remove dressings. There's pretty mixed evidence or lack of evidence on showering or washing. However, there isn't any evidence against early showering or washing. So certainly if we look at our own Australian wound management guidelines, it suggests to do a risk assessment on your patient and then consider showering or washing as long as we've got treated tap water for incisions. And then our normal recommendations that if we do have devitalised tissue there, of course, we would need to debride that tissue with the appropriate method according to your level of expertise. When we get to dressings, there's a lot of recommendations, and the top one is probably the main one: use an appropriate dressing to maintain our normal principles of wound healing, to maintain a healthy moisture balance there. There is actually quite strong. So our latest systematic review that Bridget did allude to supports the use of negative pressure for both open and closed wounds. So it supports the use of it prophylactically, not necessarily always for high-risk patients. So something that definitely worth thinking about. I've got the references at the end, and you can see the numbers there that you can look up yourself to be able to evaluate it. I like the next point. There's not much evidence that actually covering a wound incision with anything at all really reduces risk of infection. So it's almost opposite to the fact that we're using negative pressure perhaps to improve healing, and yet we don't actually have much evidence on the type of dressing. And because of that, a fairly strong recommendation that there's no need to use an advanced dressing over a normal dressing, unless, of course, you've got somebody at extremely high risk. There's recommendations just on basically avoiding further harm, when to seek help. So if you are looking after wounds and it's not progressing, we can see that there's a change or an increase in exudate and or pain, that you're starting to treat that infection with whatever means and it's not resolving within 2 days, or it's increasing, then this is a big red flag moment that we need to call upon extra help, or we need to do a reassessment and reconsider our plan of care. And prevention, moving on to prevention. So really only a couple of slides on good evidence on managing a surgical wound. But preventing, so this often boils down to a lot of patient education, which I'll get to in a minute, but trying to avoid smoking before and during the time of surgery. There is reasonably strong evidence to use prophylactic antibiotics if appropriate. So again, this relies on identifying patients who are going to be at risk, whether because of the type of procedure or the type of patient or the comorbidities that patient have. It relies on identifying that patient at risk and then using the antibiotics during surgery. Optimising glucose control throughout the perioperative phase has been shown to make a big difference in surgical site infection rates, whether the patient has diabetes or not, so with every patient. And then, of course, a lower level evidence recommendation, but only because the research hasn't been done, to ensure optimal levels of nutrition for healing. The one that my heart is in is offering consumers and their carers and family information and advice on how to recognise and how to look after their own wounds, particularly in the current time where they're doing a lot of that at home. So I just think we give patients education before they leave hospital, but it's often verbal. It's not always written down. And we know that people will only take in 10% of what you say, even at the best of times. They need something to take home that they can look at and remind themselves in a week's time when they notice they've got a sudden little spot that looks like it's about to open. They'll go back and have a look at it. And I've got a couple of examples there of patient information leaflets. And the best way to really develop these in your own workplace is to ask the patients themselves. And I know when we did started to develop some CSI brochures, you can see, maybe not. You can see on the left, on that brochure there, there's a green tick for what should I do and what should I not do. And that actually comes from patients who said to us and family, look, I actually don't want to read the bit on the left-hand side, which talks about healing surgical wounds. I just want to know what I should do and what I shouldn't do. And the examples on the right-hand side here are from another group that I work with, a patient advocacy group with the UK. And I do really like, we had a larger consumer group involvement in this one, and I really like the headings there, what should I be doing at home? What should I expect after surgery? What should I look for on the dressing, with pictures of the dressings and pictures of a little bit of exudate coming through, and what it's going to look like, so that they know when they need to contact somebody or when to go back to the GP. What are the, a picture of signs of infection, what are the red flags? I think if we did a really good job in this, we would really help in being able to detect these problems much earlier. And a lot of the consumers on that group in the UK were people who had been discharged home and just didn't know if they should bother the doctor or go back, and so did not go back until they were in quite a severe state of infection or dehiscence. So the guidelines that were in that summary are on this slide, and I believe the slides will be available, and the link to the resources are also on that slide. And I would like to particularly thank many of my partners in crime who have spent many hours going through literature and through recommendations, Helen, Christina, Kerry, Fiona Marie, Emma, Kim, Pete, Juliet, Pat and Anne Student, who have been both wound experts and wound lovers and spent a lot of time. Thank you.
Yes, Kathy, I think it is important to make sure that we give our patients some written information to take home with them, because your idea of a lot of exudate on a wound and a patient's idea and my idea and your next door neighbour's idea are all completely different. So, and is that bruising? Is it multicoloured, or is it red hot, fiery, nasty? Some people get very, very distressed by what's normal, and they need that information so that they know that this is normal, to sometimes get some discharge or sometimes get some bruising. And if a surgeon took a hammer to your hip or whatever, it's going to hurt. So some pain is normal. So yes, it is very important, and I agree, we do sometimes forget to give people the literature that they should. Have we got any questions from the floor? No, and no questions online?
Good day.
Okay, well, it sounds like we've met our goals of our surgical focused evening this evening.
And so our evening comes to an end. Thank you to those who've attended in person and to those who've attended online. As a member of the Queensland Committee, I'd like to thank you for participating in our event. We will have some other ones later in the year, as there are also several across the other states. In Queensland, our next event, other than the conference, which is in May as a national conference, the Queensland Committee intends to put on a full-day wounds education and workshop day in Toowoomba. It will be in June and it will be a webcast as well. So we're just in the process of finalising that program. We have been to Toowoomba in the past, a couple of years ago, and it was very well received, and we hope we can bring the same kind of response when we go back to Toowoomba again. So that information for trade and for members will be available in the near future, once we've just confirmed bookings. As I'm sure you appreciate, the COVID world is a little challenging at the moment, but as everything's settled down, we should be able to finalise some things. So for those of you who'd like to attend, we look forward to seeing you there at our next event, or say hello to you online. So thank you for this evening. Thank you to our presenters, Jennifer, Bridget and Kathleen. We appreciate them taking their time to share their knowledge and skills with us and with all of you at home. And we hope you've enjoyed the content of our presentations this evening. We try to have a variety of topics to cover a broad range of colleagues, because, gee whiz, we come from such a vast variety of workplaces and work experiences. So thank you for joining Queensland, and we'll see you again at another event. Good night.